Serena, will you begin recording? Thank you. All right, so let's go through the roll. I'll call you by first name. Bill?
I am here.
Great. Bob? I see you, Bob, but you're muted. I know you're here.
I'm here. Thank you.
Dorothy? Oh, I got a message from Dorothy that she won't be able to attend today. Jody? Louise?
Good afternoon.
Good afternoon, Louise. Mika?
I'm here.
Hi, Mika.
Hello.
Mike?
Here.
Great, thanks, Mike. Natalia, let me know that she'll be about an hour late. Paul? Ross?
Hi there, I'm here.
Hey, Ross, how are you?
Good.
Stacy?
Yes, hi, I'm here.
Hi, Stacy. Todd? Well, we'll mark him down when he comes back in. And Vicky?
Good afternoon, I'm here.
Welcome. And Wes?
Good afternoon, Ms. West.
Great, thank you. Well, welcome back. While we had a little bit of time between our meetings, we've started having meetings every other month rather than monthly. So, and here is, I see Jody coming in, so we'll mark her present and say welcome to Jody. So staff right now is working hard on implementation of the benchmark data call. That is a lot of the focus of staff work. We have sent out, we've identified the carriers that will be subject to the data call and sent out an intro letter and the survey of provider total cost of care contracts. You may recall we had a presentation about the fact that we are looking for confirmation that we're selecting the largest providers, and one of those factors is the existence of total cost of care contracts. We're also expecting our truncation study from OnPoint, and here's Todd. And we had an initial meeting with OnPoint about our cost benchmark report development. And as you, our cost driver report development. That is a separate effort from the cost benchmark. It's based on the all payer claims database, and the board has expressed some parameters for that cost driving report, and we're getting started with some design. As I shared with you in my email, it just feels like cost analysis is everywhere right now. There's a lot of work to be done looking at all the different reports that are coming out. CMS, of course, put out its actuarial report. We've got Washington Health Alliance's total cost of care tool, OIC's price utilization tool. NASHP is debuting a hospital cost tool. So I think our community is, I mean, there's always been lots of information on cost, but right now we have several new tools coming online, and also working to make sure that we understand the difference between them. Because of course the board can take notice of that data, and we want to make sure that they were putting it in context and using it in the right way if they do take notice of it. The board also requested a presentation on COVID and inflation. I don't know if you listened to the board meeting. I'm going to present that information to you today so that you can see what they saw and kind of follow their discussion about that. There continues to be great interest in the board on looking at the causes and context of cost. I think in part spurred by all of these tools. So in the words of the benchmark, we call that developing countermeasures, looking carefully at what we need to measure. And we had one of our board members specifically requested an analysis of labor costs. So it looks like the board may be moving forward, trying to do some ad hoc analysis on labor costs in Washington. And so all in all, we're moving out of concept and moving forward with some of those concrete deliverables, including the data call. And it'll be a long while before we see data, but we're preparing the groundwork for that. So let me go into our first item on the agenda, which is the presentation of our meeting minutes. I hope you had an opportunity to review them. Is there any discussion or corrections on those meeting minutes? All right, can I have a motion to approve?
So moved.
Thank you, Mika. A second?
There's second,
Bob.
Okay, I saw Louise lit up, so she gets the honorary second. She's where I can see her on my screen. Thank you, Louise. And all in favor?
Aye.
Aye.
Any opposed? All right, well, we'll approve those minutes and put them into our record. So now here's the topics that we're going to talk about today. We're going to review the strategies for reducing cost growth. This is something that the board looked at. You're going to look at it as well. You'll see a slightly shorter presentation about considering data on state healthcare costs, and I'll give you some contextual remarks about their questions and comments and what they look for in that. We're going to look at the impact of COVID on the benchmark discussion. I want to introduce you at a very high level to a new board requirement that came down from the legislature, which is about primary care targets and expenditures and incentives. And then we will look at the benchmark reporting discussion, which you recall we visited last time. I am hoping to get recommendations from this group, at least at a high level, about some of the process of reporting data. So we'll go more into what that's going to be and how we would like it to happen toward the end of our meeting. Okay, strategies for reducing cost growth. And you'll remember the blue slides are the ones the board saw. So I'm showing you what they understand is happening. So we've seen this cost growth logic model several times. This is something that's developed by Baylett and Peterson Group, our Peterson Millbank funders. And this is their, as you see, it's their wheel of what the cost growth benchmark activities. And what they're really emphasizing here is the part where we want to identify opportunities and strategies. And that in the world of the cost growth benchmark is firmly based in measurement and analysis. So, and now we're going to talk about how we look at that to identify opportunities. And there's two approaches. One is a specific strategy to address cost drivers and cost growth drivers identified through analysis. So that would be probably talking a lot about our cost driver analysis that we're working on with the APCD. And as I mentioned, there are similar cost driver analyses coming out in our state and nationally, although in Washington, we're most interested in things that are specific to Washington. So that would be some of the examples of a very specific strategy to address a cost driver would be some of the activities our newly created pharmacy affordability board may undertake. Very specific analysis, very targeted cap, things like that. It's data-based and specific to a particular problem. The other approach is a broad-based strategy that may impact overall cost growth without targeting one contributor in particular. I think the best example of that might be value-based payment. It's a broad-based strategy. It may impact overall cost growth. It doesn't target one contributor in particular, and that's about as broad as you can get. It's market-wide. So those are the two types of strategies the board is considering, and of course there's a range in between.
Annalisa Mikasonen.
Yeah.
It was confusing to me why you use the term cost driver and cost growth driver, as if they are two separate things.
I'm sorry.
Can you elaborate on that?
I shouldn't. I should use the term cost driver. To me, cost growth driver and cost driver are the same. Whether it's driving the growth of cost. I'm sorry, Mika, I was confusing unnecessarily.
Thank you.
No worries. Thanks for asking. I appreciate it. So the board reviewed some strategies to address cost growth in other states. I think most of you are very familiar with these. This is the Baylett presentation again about Washington, and you see that Washington is listed in some of those that we are taking an active role in. Market consolidation oversight was something that they discussed. Price growth caps, prescription drug pricing legislation, and advanced value-based payment models. So this was kind of a very quick overview of what's happening in other states. The board is embarking, I think, I know, is embarking on kind of an educational process to level set about what's happening in other states, the difference between targeted initiatives and broad-based initiatives. And I'll remind you that we have a range of experience on the board. Not everyone is involved in every aspect of healthcare. A lot of them are purchasers. There's a couple of economists. So we're trying to make sure that we level set and people understand what we're talking about. Yes, Mike.
Wow, you're quick at catching my hand there.
Comes right up to the top.
Yeah, so I wanted to ask a little bit of a process
Mhm.
now question in the spirit of our role as advisors to the board as it relates to the delivery side. And my understanding is there aren't any providers that are actually board members. So, you know, you have a unique opportunity to talk to provider organizations and gathering insights into some of these conversations. And it just seems a little bit like we've got the cart before the horse on some of these things that we talk about. And I just want to register my concern for the record that you know, the whole point was the board, prior to asking any input from this body, already identified criteria for strategy selection without any input from us, to my recollection. And now that criteria has been established, which then kind of then steers you in a direction towards some very specific strategies that have been reflected upon. I guess I would have expected for what it's worth, a process more by, you know, let me ask a group of providers and industry experts in the delivery realm to opine upon what some of the high value targets might be and see if that group could come up with a collection, and then cross-reference that to maybe what other states are doing. Instead, I feel like we are just going toward other states and having a group of non-providers establish criteria, which may or may not be, in our opinion, the highest value targets. So I just want to make that observation about the process, and we can continue to go on because obviously we don't. It's the horses out of the barn, so to speak, but it just seems like we have, and this seems to be a sort of a consistent theme from my standpoint, that we're being given, instead of being asked to reflect upon a direction, we're being given a direction and asked about our opinions relative to that direction. It's a nuanced approach to the role of an advisory committee. So thanks for hearing me out, and I'll definitely have points of view on what you have up here. And I'd also be happy to share with you some additional thoughts on other strategies to control cost growth that aren't listed.
Sure, thank you, Mike. I appreciate that. And I think, you know, what I'd like to emphasize is that, which is what I've been trying to say, is that this is to some extent was presented as a survey of state actions. And yes, Peterson Milbank and the cost benchmark work is always focused on what's happening in other states. To some extent, that is reflective of the effort to have state-to-state comparison and pull them together. So you're right, we routinely kind of say, what's happening out there? What's happening in our sister states? This was not a presentation that said you should be looking at market consolidation, you should be looking at price growth caps. It was showing what other states are doing, but I understand what you're saying, and I take that feedback seriously. And you know, you say the horse is out of the barn, but you know, the barn is meeting on August 20th, and I can tell the barn what we want to. And I'm not trying to be facetious. I'm just saying they're always eager and interested in your feedback. And you know, I know Jody is also in that meeting and can help express that feedback directly. So I can bring feedback both on the communication loop and the need for improvement, And I can bring feedback about, here's what we think about the strategies that were presented to you and whether they would work in Washington or not. Or so let me think about how to do that, as because right now I'm just showing you kind of board slides. This is what they saw. And then I want to pause toward the end of this and make sure that we get feedback rounded up about this section so that I can bring that back, Mike. Mika, I see your hand up.
Yeah, thank you. I would certainly second what Mike is saying. It is very important. Just with regard to this slide, it would also, I think, be very valuable to know what strategies they tried, considered, and failed at, or they thought didn't work, in addition to the ones that they're using and which appear to work. Because I think when we get a very select group like this, it's hard to figure out whether or not those fit with us necessarily and what else was looked at and what else was considered. So just for a broader perspective, and I'm sure the consultants have that information.
They do, and in fact, you're echoing a board request. So I expect to see more from them about what was tried and failed. They're also very interested in what the legislature thought about passing and didn't. So you're in the same thought about, let's look at rejected experiments as well, or failed experiments, not just these ones that they've adopted. So you're in tune with the board there, Mika, and I expect that we'll see more of that next month. Okay, well, I'm going to move on to the next slide.
So do you want feedback on these, or do you want to wait? How do you want to process what you're asking?
Well, yeah, so I'm just sitting here thinking that the board didn't, this was a learning presentation. They didn't actually adopt they didn't say, we want to investigate price growth caps. We want to investigate prescription drug pricing. What they heard is that other states are doing some of these things and why, some aspects of how you can do market intervention. So I don't think that I want this group, I'm always open to comment, but I'm not sure if discussing it as a group, what do we think of market consolidation oversight in Washington? Because there's not enough specifics here. Washington, market consolidation is a pretty big topic, right? And it involves, so I'm trying to think about it. I guess,
Go with your plan. I just trying to be a good student and provide you what you're looking for. And wasn't sure if you were asking for input or if you're just wanting us to be in the listening mode.
You're always a good student. What I want you to do is give me, what I want you to do is understand that this is an educational thing about categories. And these are the categories the board saw. What I would like to hear is if you think that there is a category here, let's pause for a minute, since you guys are following this, and say, so they are looking at these 4 categories and they're examples of direct and system intervention. Is there a category here that you would categorically reject for Washington? Let's just go there. Is there one here that you'd say this wouldn't work here? Or is there one that is not here that I need to pull together an educational presentation for the board on? Because that's where we're at. We're doing educational presentations, which are, here's what the intervention is, here's what other people have tried, here's how it looks there. So I'm going to ask for feedback, and you can give it to me later, because some people don't do it on the fly, Mike. Some people but if you see something here that you think, oh, I don't like that, or that would be great, or something that's missing, I'll open the floor for a minute. I bet you see something, huh, Mike?
Yeah, price growth caps. We are in a period that hasn't been seen for 20 years. While medical cost inflation in terms of my suppliers are going up by double digits, but the government payers like Medicare and Medicaid have very anemic growth rates built into their cost of living, which does not even exceed 1%. And health plans contracts don't open for renewals to match the inflation. So if I owned my coffee stand, I could increase the price of my latte in order to afford workers. And people may not buy as many lattes, but I at least could not be upside down in the price versus reimbursement equation. So much like the COVID conversation, you know, layered on top of that now is macroeconomic issues around inflation and supply shortage and supply chain. And those are things that traditional delivery systems have very inelastic business models that don't operate in traditional supply demand curves based on the way pricing works. So price growth caps would be one that I would want to be very careful about in light of where we're at in the macroeconomic world of the economy.
And I think I heard some similar concerns from board members as too. I mean, it's a pretty blunt instrument. Other comments on this list or price growth caps or whatever you want to comment on? Ross?
Yeah, I'll just add on the first and the fourth, you know, Washington is being called out there, basically suggesting that we're already doing it and probably are. I guess my curiosity related to this, and maybe it's behind this slide, but how has market consolidation oversight curbed cost growth, and likewise, how have advanced value-based payment models curbed cost growth? I'm an actuary, so I want to see the proof, but that's my reaction also to this list.
Great. And I think that is also, the board definitely asked, where's the proof, especially when it comes to value-based payment. So one of the things I was asked to do was bring a value-based payment in Washington, kind of a deeper dive into how it works, and show what evidence we have that that's lowering cost. And, you know, so we're working on that presentation now with the folks who run that program. So you are all tracking kind of the board's reaction to these. Bob.
Thank you. You know, this is a list of what people have done, but there are a lot of things that people have talked about that you don't have on the list, and you know they don't have a lot of proof at this point, except for in certain places. The one that comes up is the drug pricing. If you look at the VA, they're able to negotiate prices as a group, and they're able to get much better pricing than we get in our state from the commercial side or from the Medicaid side. And I just think, while we each individually can't do that, we as a group can weigh in to enable certain sorts of negotiations that may, like that. That's just an example of things that are left off that I think that are things we should think about that have at least some evidence behind them. And I think in the value-based payment areas, there's a lot of mixed results, but it has a lot to do with how it's structured. If you have the right kind of a structure behind it. And so the question is not whether the model works, but rather whether the structure that puts the model together works. And that requires, both of these actually require groups that are now very individual, all the people on this call, actually working together to do something. And I just bring that up as a huge challenge because getting people to work together is very difficult. But I think that we're not going to be successful in a lot of these if we don't have agreement and some sort of coordination between us.
I think that's a great point, Bob. Thanks for making it. And I agree, this is not intended to be a comprehensive list of possible strategies. We're working in a 2-hour time frame. So again, back to the survey of things that our consultants are quite familiar with that other states in the Peterson-Milbank program are doing. I think that's kind of the paradigm they were using. But if I'm also hearing a flavor of, you need to widen this out. You need to involve us in the conversation, and you need to possibly add some things. So I heard from you, Bob, that there's a couple things to add. I appreciate that. Any other comments on this slide right now? Okay, and the reason this is only one slide is because, again, I was like, well, it's an educational presentation. There were some additional slides in the board packet that dive a little more deeply into each of these. You can go to our website and download that, or I can provide that to you. I cut it down a little bit in the spirit of it being an educational session. And I think probably most of you know more about these efforts than perhaps some of the folks on our board. I'm not sure. I'm going to move to the next slide, which Mike, you've anticipated, which is the criteria for selecting strategies. So this is criteria that is similar. I know this sometimes causes heartburn, but similar to what's been adopted in other cost benchmark states. And what it's really doing is putting forward a checklist that says how we want to deliberately support selection of strategies, how we want to be sure that we're thinking. You notice it talks about it should have a substantive impact, and we want evidence and data. I think that's kind of self-evident to many of us in this room who want more data to support cost growth benchmark attainment or cost growth reduction strategies, but it needs to be stated. So the board is kind of committing itself to saying, we're not going to move forward unless we know it's going to, with a recommendation to implement about a strategy to implement, unless evidence supports it or there's a compelling logic model. And that's the slide we looked at before, the two ways to look at it. There's a specific intervention or a compelling logic model for the strategy. I would say, Bob, kind of translating what you said about value-based payment, there's a compelling logic model for value-based payment strategies, moving into more value-based payment strategy. And clearly our state has kind of agreed with that because we've been pursuing value-based payment. But then the response to that is, where's the specific data about cost cutting? And that's kind of the line the board's walking there. Mika, I see your hand.
Yeah, thank you. I was interested in the sequencing here, that the stakeholder involvement is really at the end. And that may be just sort of the way the slide got together, but I really think that the stakeholder part of this has to be very close to or at the top, because they're really the ones who have to sell this, institutionalize it, and work through their delivery systems to be able to deliver on this. So that's one comment about the sequencing of the bullets. The second is that the key part that I think is missing is that that any process we go through should not create harm to access or to other sectors of healthcare. And I'll give you an example. We could say, for example, let's get rid of all primary care in the state. That's implementable. It would have a substantial impact on cost growth. It would be actionable by payers and providers. And we have the capacity to design and execute on that strategy thoughtfully and successfully. But we would never do that, right? So this is a necessary but insufficient list of topics because it doesn't include that do no harm category.
Okay, I've captured that. I think that's very thoughtful. I think, to some extent, I think I can't imagine that the board would object to considering that principle, and I'll bring it back. I think they have approved these criteria. I don't think there's any problem discussing with them others or different. In fact, they specifically added the approval from federal partners not being required. Several people were concerned about the roadblock, to certain changes in Medicaid purchasing. So other comments from folks, and I don't think the order has anything to do with the importance. It's simply how they came together in the slide as people talked about what was important to be sure that they held themselves accountable for. Let me ask you this question, Mika, just because I don't know the answer. So what if there is a strategy that, you chose get rid of primary care. That's pretty, I think we all agree we're not doing that. What if there's something a little more, it looks actionable. Will it have an impact on access? I'm not sure because we don't have the data yet. How should they handle a situation how will they know that it's going to have a negative impact on access, a strategy?
Well, but I think as a bullet point, what we need to do is to include an assessment of the negative consequences or adverse consequences of any strategy to balance out the perspective. Because if you just go down the list of things there, it could lead you to do things which we wouldn't choose to do because we're including other criteria, like not getting rid of primary care, right?
Yeah.
Nobody would do that, but it's not in the list of things. So we just want to make sure that we've been inclusive in our strategy.
Yeah, and
component.
I like that. I like that it's an actionable include an assessment of adverse consequences. For some reason, that just Annalisa, that clicked in my head a little better, like, oh, I can do that. I can include an assessment. And this team would obviously be, this advisory group would be very important in kind of anecdotally figuring out the negative consequences, whether we can get data on it or not. So I think that's a good suggestion. Other thoughts about this criteria for selecting strategies? So these are the questions we'll ask every time before we select a strategy. Mike.
Oh, well, so you're just asking about the criteria. You don't want at this point to think about areas that might meet this criteria. Is that right?
You know, I don't want to right now. Yeah, I want to focus on the criteria.
Okay.
So that we're asking the right questions.
Okay, fine. I just would like to, as long as I took myself off mute, I would like to really endorse the point that Mika just made, because the last thing that we want to do is something, I've looked at, there was legislation in this last legislature, for instance, that would have harmed the health of our health system. And when compared to states that have adopted it, it's empirically proven. So we absolutely need to ensure that we have criteria around that there's an evaluation of unintended consequences to the quality of care provided and the equity of care too. I mean, I think we need to evaluate these solutions through the lens of healthcare equity. Just as another consideration to what Mika just said.
Yeah, I agree. And that we've heard that feedback from members of this committee and from the board. And that kind of came up under the discussion of what are we concerned about? Remember those conversations we had? What do we need to be careful of as we look at reducing the cost curve? And both of those came up very strongly. So they've been reported to the board, who of course agree with them as well. We need to be looking at access. We need to be looking at quality. And so in the parlance of the cost benchmark, we call those countermeasures. So we've had some initial discussions on countermeasures, and those things are certainly included. Any other comments on the criteria? Okay. So I will certainly bring back the comment. Can I get it in deference to what Mika we talked about last year about whether that is a strong recommendation from the full committee or whether I say one member thought this would be a good thing. Can I get people to, what I'd like to do is have you let me know if you agree that the criteria should definitely include a statement about not creating harm to access and including an assessment of adverse consequences about access. So I'm going to ask if you agree with that statement to please raise your hand and I can get a quick count. So I know how strongly to state that in my minutes. So just put your hand up on your screen and I'll count if you think that should be an important criteria that should be added to these criteria. I see Ross's hand, so I'll count your real hand. 1, 2, if you don't know how to use your hand thing, there's Judy's. Okay, 1, 2, 3, 4, 5, 6. Okay, great, thank you. That appears to be a strong recommendation of the committee, and that's how I'll characterize it when I bring your feedback to the board later this month. Okay. Now we move on to, again, another educate. And now I can't tell because I asked people to raise their hand and they're still up. So I'm going to call on you, but if you don't want to speak, please just let me know. Vicki, I see your hand up. Oh, okay. It went down. Right. Oh, no, that's fine. It's this new world. I just don't ever want to not allow someone to speak if they want to. So we're going to look at what the board looked at in considering data on state healthcare costs. This refers a little bit to the issue that I talked about earlier. There is a plethora of data and reporting. So I would call this again an educational presentation to the board about what people consider and what data they're looking at. So again, this is a somewhat shortened presentation in the interests of time. So not every slide the board looked at is here. If you wish to see every slide they looked at, I encourage you to go look at the board materials, and the meeting is of course taped, so you have access to all of that. Or you can email me and I'll send you the board book. But these are the questions that Baylor Health asked the board to consider while reviewing data on state healthcare costs. What does the data say about where the costs are rising highest and fastest? Do you identify concerns we should consider when interpreting data? And what analysis should HCA consider to better understand what's driving spending and spending growth? So this is a selection of the slides that the board was educated about. And I think what's most interesting to me is the different sources. So this is the 2018 Healthcare Cost Institute, and it's showing an increase in prescription drug spending significantly higher than the national average. So this was created by the Healthcare Cost Institute. In some sense, these slides are meant to inform how the board wants to design its own cost driver analysis. Because you know the focus of the cost benchmark work and of the statute is to have Washington data. So to some extent, the discussion was about, how does this, do we agree with this? Do we think that prescription costs are rising this way? Do we like how this is represented? Does it make sense to us just from what we know about our context in Washington? So they're certainly not saying, I want this presentation, educational again. They looked at the Office of the Insurance Commissioner's cost trend analysis. Now, since that's Washington specific, I've created some, I created this little slide to educate you about what it is. So that's Commissioner Kreidler asked OnPoint to use the APCD to calculate the rate of cost growth for commercial spending. And that was from 2016 to 2019. They used data from the APCD. So this is not, this is pre-COVID. And they were specifically interested in these categories: acute inpatient, outpatient ED, outpatient non-ED, professional pharmacy, and ambulance. They are only interested in price utilization. They're not doing some of the other things that our statute tells us we need to do, such as by region and by demographics. And then they did some drill downs that they were specifically interested in: the type of inpatient services, mental health services. That is in part due to the fact that they've been working with a federal grant for a couple of years now around mental health parity, which is their regulatory in their regulatory sphere. So they are studying that. So of course they'd be interested in mental health. They're interested in air ambulance services, which is kind of a perennial problem, especially now that we have federal surprise billing, and we have some significant issues with the cost of air ambulance to consumers, especially out in our island county. And then they wanted to look at the exchange and PEB. And so I'm sorry, I kind of anticipated this. This is their methodology. I'm showing you this also because it's likely that some of this will be very similar to what the board does. I would call this a fairly straightforward price utilization analysis, although those special categories that reflect the OIC's interests are certainly, perhaps unique to them. But, and this is an example of a key takeaway from OnPoint. And OnPoint's presentation was pretty long. So again, if you'd like to look at what they're presenting, go ahead. Go check the board record. So this became a the commissioner's office put out a press release on this, that PMPM increased by 11% between 2016 and 2019, and driven by price and utilization. Now that is what I would call, an initial kind of survey slide. There's not anything particularly actionable in that. It's telling us that price went up in Washington. So that would be the first level. That would be what Baylett has called a phase 1 analysis, to be followed up by a second, more pinpointed analysis to determine if there's some area. And of course, you couldn't do it on this slide. You need to do it on some of the other slides, perhaps looking at conditions or perhaps looking at sectors of the, of service. You might be able to find something to dig into, and if one is growing faster than the other. So that's really what the board was looking at, is how do you use an analysis like this to pinpoint areas that you might want to look at. Then we looked at a very high level at Washington Health Alliance's total cost of care tool. I'm glad to say that they're going to be coming back in a couple of months and kind of doing a deeper dive with the board on what their tool is and how it works. Oh, I'm sorry, hands, I got carried away. Louise.
Thank you. I have a question about the previous slide. I can't remember a time that healthcare spending costs have gone down. So it's no surprise that healthcare costs go up. What I'm wondering about, well, actually, I do see it went down, utilization went down. So I know that you're going to talk about COVID later, and this is a time frame pre-COVID. And I keep pondering, if we have all this information that's pre-COVID, what COVID will then do and how there will be an adjustment. The other thing I'm wondering about is whether or not this is adjusted for inflation, or if this is simply an absolute cost increase in spending. It's absolute dollars as opposed to percent increase adjusted for inflation.
Louise, I don't know. And I'm happy, I will contact On Point and get that question for you. But I'm going to point out that is exactly what the kind of questioning we were hoping the board would do, practicing kind of saying, what does this actually mean? Have you adjusted this for inflation? What does it mean that utilization is what does it mean that utilization is at 6% and price is at 5%? So I will follow up with you and let you know if this is adjusted for inflation. I don't know the answer to that question, but I think it's a great question.
Yeah, and the other thing I would say is it's always hard to know what was changed in coverage. So because I am looking at this and seeing that there is a decline, I'm just trying to look at the colors. So a decline in price per member per month. And so what accounts for that decline? So it's there, but what accounts for it? Is it because the health plans decreased reimbursement, or because it comes at a time when utilization actually increased? So I'm just trying to, so price went down. Is that what I'm seeing? Price went down, but per member per month cost went up?
Yeah, well, you're seeing that price over the years went up and then slightly down and then up again for an overall of 5% growth. But I see what you're seeing, that between 2017 and 2018, price went down and that utilization went down a lot between 2016 and 2017. And I don't know why that is. Again, the demonstration is that, well, that's interesting. So you've got some numbers. You have to dig underneath that and say, what caused that utilization? And it could be two things, Louise, and you've mentioned both of them. It could be that there's something in the data. Is it adjusted for inflation? Is it, is it dealing with reimbursements, or is it dealing with a different kind of spending? And then the other question is, what in the context of the market is causing that? Did people go to the doctor less? And if so, did prices rise between 2016 and 2017 because there was less utilization and we needed to charge more? And that was the object lesson of this presentation, is that you can't make assumptions based on a chart.
Yeah, and I would say my other question when we talk about price is this the price from billing or from reimbursement?
Yep.
Or from contracted reimbursement? Because there's there's more than one price.
Right.
Because somebody can bill, but then if you have a contract, you're not going to get what you bill, you get what you contracted for. And then if you're not insured, then you're probably going to pay what you were billed, but you may not pay what you were billed if you can't afford to pay what you're billed. So I'm just not sure, without a key here, what does price mean?
Yeah, my understanding is it does mean price paid, but I would not want to be put on the witness stand for that. So I have to, so that's another good question. And as we head toward our own analysis, one of the things is when you're involved in the design, you know the answers to those questions because you've directed them about how to do it for each one. So again, a good question. Sorry, I don't have more answers for you today, Louise. I'm not an expert in the OIC database. I hope to be better at it soon.
Okay, thank you.
Thank you. Nika, you were next, and then Mike.
Thank you. I certainly agree with Louise's points. I think those are critical questions. The whether or not it's indexed to inflation and what the exact number or what the definition of price is. I wanted to go back to the slide where you have the 3 key questions. If you could go back to that.
Mm-hmm.
Yeah. The assumption in question 1 is that the place you're going to find the most actionable opportunities are where costs are highest and where they're rising fastest. But that is an assumption. If you were to ask somebody like Mike running a major medical institution, where are you likely to be able to cut costs? Where are you most likely to be successful and not harm access and quality of care? They might not be in the areas where the costs are rising the highest or where the costs are greatest. There are other criteria. So I just want to point out that question number 1 has a lot of built-in assumptions that I think lead you down a pathway of that somebody who looks at data only but doesn't know healthcare, doesn't run a system, would not necessarily consider. And so I think that there's at least one other point that needs to be made on this slide is, where do healthcare professionals, the people who run the systems and work within the systems, feel that there are the greatest opportunities? And I'll give you an example. I also sit on the Healthcare Technology Clinical Committee for the Healthcare Authority. And we don't review subject areas that are the highest cost or the highest growth cost. We review areas that have been raised where the value proposition is really questionable, where there may not be data to support the value proposition. And that is all focused on trying to bend the cost curve for the state, for L&I, for corrections, for all of the other groups that we represent. So I think there's a step 4 here of where do healthcare professionals, where do we on the advisory committee and those we represent feel are the potentially greatest options for making a change?
Well, I think it's a great question, and I'd be happy to put that. I think we should put that on our next agenda and give it to you as homework to talk about, just kind of a list to add to the list. I mean, I remember last time we talked about, the board had kind of reviewed a very broad list of things it could learn more about, including the board that you just mentioned, and the BRE Collaborative. And if we want to create a list of, here are interventions that we think you should learn more about. Remember, we're not at the point where they have their own data to kind of lead them through a better analysis of those interventions. I think of it as almost an education list, like, let's learn more about it in preparation for what our data may show us. But I think that's
right,
a great topic idea, and I'm happy to put it on there.
And it's also, where do you ask for data?
Yeah.
It's not just where the costs are going highest and where they're rising fastest. It's where Mike says, hey, in my system, I think there's the greatest potential to find cost savings in these 12 areas.
I think that's a great idea, and I've marked it down as a future topic. You know, sounds a lot like, I mean, we'll also have to be looking at the work the Health Alliance has done with its, you know, as you talk about waste, of course, waste is directly related to cost, and that is another data set. So the board, as I said, can take a look at, I consider that data as well, you know, our community report cards there, so that we can look at lots of data, and that would be in some ways another stakeholder provider carrier group talking about what it sees as waste. Bill, I see your hand.
Yeah, and I would just bring up an aspect to build on some of what others said, but when aggregating measures and then saying, hey, this is a key finding, trying to fit everything into a utilization and especially a price bucket, there needs to be some consideration of the severity, would be one thing to look at. Especially when you're talking utilization, depending on how aggregated it is. If I'm counting every encounter with a provider as utilization, a tremendous difference from year to year over whether they're coming in to get a flu shot or a COVID test or a COVID vaccine versus they're coming in because they have a, you know, serious medical condition. Right. So that aggregation into the category called price, it's just there's all sorts of underlying dynamics there that you need to have an understanding of to really understand what the true drivers are that's causing that overall PMPM increase.
That's absolutely true, Bill. And I do happen to know, having had some initial conversations, that on point that they do, they have a severity index that they use to talk about. And so there is some risk that comes into the category of risk adjusting that data to ensure that you're not skewing it for either, you know, demographic characteristics or severity. So that's very important. It's a good point. Another underlying question of the data: are you correctly representing what's really going on and kind of focusing on price, all other things being equal? And that is part of how we have to construct a data call or an analysis. Okay, I'm going to go back down to the, and I'll stop if I see more hands, but so this is an explanation again of the OIC methodology. And then here's an example of their takeaway. You saw that. So now we're talking about Washington Health Alliance. So they are drawing from their own database, which is a little bit different than the APCD. As you know, it contains self-funded claims information from their membership. It's reported on a PMPM basis. They do something a little different. They set a state average as a benchmark to allow comparison of costs across geographic areas. And they've got a tool that you can view in all of these different ways: geographically on a state map, by setting, by service, Medicaid and commercial, year over year. So that's a pretty high power. I mean, we'd expect nothing less. That's a great shop with a lot of experience, and they have created this tool for our use, and the board will be looking at this as well. And as I said, we're going to get a deeper presentation on this. So I'll let you know if you want to come and see this tool demonstrated by, probably by Mark Prigler. I'll let you know. So this is an example of something that we have, of a resource we now have from the total cost of care tool. So you can see that they are looking at, now this is the first one we've seen that's gone into the COVID period at all. And as we would expect, it's down, except for prescription drugs. And the downward trend in 2020 occurred nationwide. So again, I'm not going to be able to answer detailed questions about the design of this database because it's not mine. This was more of an educational presentation about this is how you can set things up and look at them when you're doing a cost driver analysis. And I know many of you may be members of the Alliance or have access to their database and may know more about this or have resources to find out more, but this is I think this is pretty impressive work. So the board identified these areas for deeper dives. And by deeper dives, that means I want to learn more about how it works in Washington. The market oversight was a lot of questions about what is happening in Washington. And so people threw out ideas about, so how does it work with certificate of need? How is it working with, what does the commissioner's office do exactly? Because there is, remember, they have knowledge from different areas. So the commissioner does have a process to look at consolidation, and people were curious about what that was. Curious about what the Attorney General's office is doing. Curious about how the certificate of need process may or may not fit, and also asking questions about Oregon has a new approach to market oversight, a new statutory approach that I believe was passed last year. I don't know much about it myself. So they are interested in learning more about market oversight and setting affordability standards. So we're going to bring back some educational material for them about that, about how it works in Washington and what it looks like in Oregon. That is different. That's why I'm going to links to explain to you that's different than saying, I want to make a recommendation about market oversight. That's not what they're saying. They are interested in looking at hospital pricing strategy, including global budgets and labor cost. So this is one of our UW economists, Bianca Frogner, who sits on the board, does a lot of work with labor costs and volunteered to bring back to the board some recent information about the costs and impact of labor in healthcare, in the healthcare market. And they were very interested in that. Margaret Stanley was specifically interested in global hospital budgets, what that looks like, how it works. So again, educational. And looking at examples of what hospital pricing analysis looks like at a state level. So I'm not aware that we have one here. NASHP, I know, just came out with a hospital pricing tool that I haven't investigated very much, but that came up in conversation. We might like to learn more about that tool. And I'll stop and get comments about this if you, and I realize I've got a room full of potential experts on any number of these strategies. And then value-based payments, and you'll see in particular challenges to getting traction. So what that is about is kind of what we talked about. Where are we with value-based payment? Exactly how long have we been working on it? And what is the data that you have, really, Healthcare Authority, about the efficacy of that? How can you prove to us, how can you take it from that logic model, which is this should work, this should advance both quality and lowered cost and higher value. So to some extent, I think partly that's based on the fact that the board has a lot of people who've been involved in healthcare for a while and would like an update on value-based payments. So they're interested in diving deeper informationally into these issues. Mike.
I don't really have any comments for the time being on market oversight, but I definitely have some viewpoints on it. The two that I want to give you some thoughts about is hospital pricing strategy. Back to a comment that Louise made, hospital price means almost nothing relative to payments. And so when we use the terms price, we need to be very precise about our use of that term. If we're going to define it as reimbursement, if we're going to define it as cost, if we're going to define it as charge, we need to be clear that we're not talking past each other, because people who don't live in the environment don't understand the dysfunctional systems that have been perpetrated for decades around hospital and health system finance, and how they make no sense to an average citizen. When you sort of, as you move through the sentence, it says, including global budgets and understanding the impact of labor cost. So I don't know exactly what we mean by global budgets if we're talking about moving into the era of managing the total cost of care. And if so, then that's a very big topic that needs a lot of unpacking relative to the committee's understanding of what that means to delivery system. I would simplify it into two topics, which is the benchmark means there are really two things that matter. If I'm overgeneralizing, the benchmark that you start from an actuarial standpoint as to whether it's a reasonable one, and the timeliness of data so that it can be actionable. Clinicians, providers, delivery systems historically are not good at responding to data that is outdated. And timeliness of data is oftentimes a real rate limiter to effectively managing within global budgets. And then the last one, I would just stand up and applaud and say, understanding the impact of labor costs. At the risk of sounding hyperbolic, the current staffing shortage facing healthcare in particular, because of the inelasticity that I talked about earlier, is an existential threat to the American healthcare system. And so that one is one that I would underscore 3 or 4 times as something that really needs a deep dive. On value-based payments, the only comment I'd offer, Annalise, Lisa, for you is this is one where, you know, I'll look at, you know, data from, I'll just use the Washington Health Alliance, and I'll look at sort of, you know, data that represents high performers, and then I'll look at another statistic around, say, something that CMS puts out, which is like the MIPS program, the Merit Incentive Payment Program, which is intended to incent high value services that will lower the cost. And they're oftentimes inconsistent. I mean, I've seen organizations that score 100% on their MIPS scores, but are not considered a value provider in the Washington Health Alliance database. So the inconsistencies of that lead me to the conclusion that, different people are drawing different conclusions about what brings the highest value to lowering cost and maintaining quality. And so the value-based payments one is another one that, you know, your point about, in particular, challenges to getting traction. I think it's exactly around the 3 things I said. Number 1, people don't do a good job of establishing a reasonable benchmark. Number 2, people don't have timely data. And number 3, there are so many value-based schemes out there right now and noise in the marketplace that people have lost track of which one to follow as the highest value target for producing value.
Thank you. Yeah, I think, yeah. Well, it'll be interesting to see what the folks from the value-based who are closely involved with value-based payment reporting, and it'll be interesting to see what they say. I'm looking forward to that presentation. I'm sure they'll get lots of questions from the board. Sounds like if I mean, I always am very practical, as you know, Mike. I'm like, if I want a subject matter expert to come give me another perspective on hospital pricing strategy, I should stop here first. That's kind of what I heard in some. So it may be that what I hear you saying is there's things you'd like the board to understand about hospital pricing strategy, and maybe it would be worthwhile to talk about giving them some insight from a hospital's perspective rather than an academic. And I see that point. So we will be looking into hospital pricing strategy, value-based payments, and market oversight over the next couple of meetings. At this point, the board is, you know, a lot of work is going into getting the data, and they aren't part of every day discussing, you know, what kind of, you know, whether data should come in by email or in FTP server. So, you know, we're doing this instead. This is what they're looking at. So here we are. What feedback do you wish to provide? So I heard from Mike about feedback on areas and deeper dives. And notice it's also like challenges in identifying cost mitigation strategies in these areas, asking way out in advance because they're not developing them yet. And then are there other areas the board should consider in addition to these? So here's our stop with our slide that says, hey, they got some educational material. They picked 3 areas for deeper dives. I heard from Mike about here's what you need to consider about hospitals and here's what you need to consider about value-based payment. So that's kind of goes to number 2. And other areas they should consider in addition to these. So that's an open door to saying a little bit of the conversation about why don't you, ask us about what you think some of the profitable areas, some things they should learn about. So we'll pause here for a little bit and see if people want to give input. And I'm also gonna, as always, we're open for these topics at any time. Does anyone else want to offer feedback on any of those 3 areas? I'll put that slide back up again. Have thoughts about what the board should keep in mind when looking at market oversight or hospital pricing strategy or value-based payments? Mika, and then Bob.
Well, I certainly agree with the points that Mike made a few minutes ago, and I think he summarized them well. Pharmaceuticals have come up. You've shown us some data about it. They're not included in this. They are both a very challenging area to address, but also such a critical area that any strategy, I think, needs to include those. My other comment is that the deep dive for data needs to get really down deep enough so that it truly indicates to us whether or not we are going to be able to pursue strategies for mitigating or acting on these. And I'm worried that the board's push for depth of the data, since they're not going to be actually doing the work, they won't know how deep they need to go. They won't know the granularity that is necessary to be able to work on this, or the specificity of the definitions, like, for example, price, that are so crucial to know whether something is actionable or not, and whether it's a problem or not, whether it actually represents an improvement in value or a decline in value. My takeaway from that is, or suggestion is, at each one of these levels, any one of these data dives needs to be looked at very specifically by people, members of this committee, other experts who are actually going to be charged or challenged to affect these. And I will predict that will be a critical piece of the response that you get back from any healthcare system that is shown subsequently in a transparency type of publication to be a high cost place. They're going to say, you have to give me data that is far more granular than anything you've given me to be able to make any changes that are meaningful, and to know whether or not those are going to harm patients, create disequity, or create a loss of access. So the depth of the data is going to be critical. Okay.
Bob.
And I'm going to agree with the previous speaker, the good doctor, in a lot of ways. I think that, the board itself is not going to be a group that will be able to do the assessment of the detail. And, we have bodies in the state that do a great job of assessing data and making recommendations. And right now, like the BRE Collaborative, which, doesn't look at cost necessarily, but does, I think, look at cost effectiveness sometimes. And I think that they would be a body that we may want to dip into if we decide to do a strategy. Is why not get their assessment and have them give good advice. And I think that's good for everybody on this call, just because most of us believe that they do a good job and are fairly accurate in what they do, and review the literature and hear from all the different perspectives. So just a thought.
Thank you. I think that's great. I marked that down. It kind of echoes your comment in the chat a little bit about, you know, let's look at existing trusted bodies around the state that we can you know, pull some information from. And you're right, the board is not going to assess the detail. They're going to rely on contractors and experts and folks on this committee and the data committee to determine that they've gotten to the right place. Any other, so I'm still in the area of any feedback on these areas selected for deeper dives. And I'll move on to, are there challenges? Oh, did somebody, I'm not sure.
Oh, sorry, I came off mute. Just in value-based payments, you know, I think it was Mike who said the word schemes, and I think that's an appropriate word, is that there's many of them out there, and it's not just about getting traction. You know, it's really what are there other, have states had other effectiveness in making sure that these, you know, are controlling costs, as well as what are the areas? There's the BRE, the hcct committee, or I always mess that acronym up, and others that have all these inputs and all these different versions of aspects. Now, they should all be marching in the same way, but I think not just a deeper dive on why do we not get traction. I think that's good, particularly when you look at, say, smaller providers and not in systems. It's harder to get the reporting and to spend that time, but also just really what are we driving towards when we have discussions around value-based payments? You know, it's quality and patient care and making sure that that's being taken care of. Are there discussions in capitated rates and what those have done, say total hips and knees and things along those lines? Are there, you know, how much are they really sort of evaluating that as well?
That's a great question. I will pass actually some of those on as areas of interest because we're developing the value-based, because HCA staff, you know, who are, that is not my group, but I can pass some of those questions on that we're interested in knowing about maybe some of the impacts of capitated rates. Thank you, Todd. And I've captured that. I think I love the question of what are we driving towards? I think that is a question that we all have to think about as we don't want to layer another initiative on top of what's already out there without being able to have some confidence that it's going to fit in and help. Witness back to the criteria. Is it actionable? Will it be helpful? Vicki, I see your hand.
Sorry, I have a new device and I'm really struggling with it. You know, I agree about thinking about unintended consequences, you know, value-based payments, those words scare me for our rural providers because I think, you know, providing healthcare in rural areas is gets more difficult every day. We have trouble with specialty providers. So I'm wondering, when we think about those things, are we thinking about the cost of people not having access to the right kind of care? Like if you can't get access to behavioral health services, sometimes you'll just go see your primary care provider and see what they can do for you. And, you know, also I think it's really important that we have the right type of providers for people to see, because, you know, seeing the wrong provider can be expensive. If you're going to the ER and that's thousands of dollars when you could have had a behavioral health appointment that was $150, you know. So I don't know where that kind of utilization fits into this this work.
Yeah, I hear you. Sometimes it feels like it's based on a thought that all of that is available, and if we just chose correctly, we'd be, you know, it's like, I hear you. I've captured that, and we'll bring that back to the board.
Thank you.
So there's also the the last question, although maybe, I mean, not in order of importance, but are there other areas that the board should consider in addition to these three? They're teeing up the work of the next couple of months, receiving baseline education about these topics. Are there others that you think, wow, the board really should understand this, or start understanding this? Because this is such a complicated endeavor. We're going to need to iterate over and over about educating the board and driving them deeper. But additional topic areas that might be fruitful for looking at bending our cost curve, interventions or areas. Mike.
And I mean, again, I'm teeing off of the reference to impact of labor costs and my applause for that recognition. And this is maybe a statement of the blindingly obvious, and maybe it's going to be reflected in the next discussion item. But again, as we've talked about multiple times, both the impact of COVID, how that affects everything, and then what's not on here that is beyond impact of labor cost is, again, the current, again, we haven't seen inflation like this in over 20 years. And so the current inflation environment that we're setting this exercise in the context of. So those would be two things. That's probably obvious. That's probably obvious to the board, but I feel like we need to be it needs to be intentional.
That's great. I think what you see is that the board has asked that question and received some information about it. And again, that's going to be iterative as we learn more about the impacts. But I certainly am adding that to the list. Other thoughts about what should be on this deeper dive area, either interventions or areas? Bob.
Thank you. Healthcare is not a say a freely competitive environment, and it's really I look at it much more like economy or development economics, where we really depend on a structure developed by policies, be they Medicare, be they state, or whatever. And I think that we have a structure that is based on the fee-for-service system in the state primarily, and we have a number of just the prescription issue is really clear to me. The policies about whether we can negotiate as a state, as Medicare, as really as individual groups which are too small to do it, even though they may be big systems locally. We have much higher prices because we have rules that don't allow us for the market to work. And I think that's just one example of many things in a way we structure that. And while I don't think we individually can solve those problems, we as a state or as a national community can take on a lot of those issues. And I think to just think we're going to do the same thing we're doing now and really be successful without changing I'll say the framework in which we're working is probably a little bit short-sighted. And I think we have to put those on the table as well about what are those things we can support or be supporting of that more generally that may change the environment we work in. And we can get into details of that, but I think there are some good examples.
Okay, so what I'm hearing is talking about some system-wide framework issues that will interfere with the ability to turn the cost curve. And you have some ideas about what those are, and I can, but so I think that is, I think it sounds like there's a lot of potential insight in there. I need to understand as we work. I'm asking for that presentation to developing what's more in there. So if you want to talk about that offline, Bob, or you just want to give a few examples now?
Well, I might just do it offline. That'd be easier.
Great. That sounds wonderful, but I think that kind of perspective is great. Kind of a more global perspective. Other folks have ideas about what the board should consider or look at in addition to the areas that are here. Okay, well, I'm going to move on. Again, ideas that come after this meeting are, you're more than welcome to send them to the cost board or to cost board email or to me. And this is a long-term development. We're going to be working on this for now and for many more months. So there is plenty of time to talk about deeper dives. And some of you have expressed some interest in being, I'll contact you about specific programs and see what we want to talk about there. So I am conscious that I'm behind, and I think what I need to do right now is pause for public comment, although I'm worried that someone will want to comment on this presentation. Let me think about that for 1 second. I think what I'll do is go through this presentation and then have public comment, but if we get too close to the end of the meeting and haven't had it yet, I'll have to stop our conversation and do public comment. That's what I'm going to do. I'm going to move forward with this. And if we get to 3:45, I'm going to halt everything and do public comment, and then we can finish our conversation. Okay. And I'm delighted that it takes us a longer time to get through things because we have so many good things to say. So this is what the board specifically asked for a presentation about what is known now about the impact of COVID-19 and rising inflation on the cost growth benchmark program. So this is not a study of the impact on individual participants in the healthcare market. So what we saw, and again, these blue slides are what the board saw, is that utilization dropped dramatically and rebounded thereafter, but did not reach the 2019 baseline level. So these are kind of truisms that we, meaning actuaries and healthcare economists and the community that is studying the impacts of this, have noticed. Utilization is higher in 2021, but may not have reached the annual level of 2019. And then translated into what this means for states who are actively measuring benchmark now is that the trend for 2019-2020 will be low, and the trend for 2020-21 will be much higher. So the board anticipates that whatever we see will follow this. So this is putting it into context, whatever our cost benchmark results will be. And again, this is what you guys have been talking about for quite some time, that providers are affected by these issues. Looking at some national statistics, Consumer Price Index, Bureau of Labor Statistics. That's kind of an understatement. They're raising concerns about near-term prospects for meeting the benchmark. Again, this is looking at several states. So this is not simply Washington. So providers are aligned in all states that this is going to dramatically impact ability to meet the benchmark. Mika.
I would add unprecedented levels of staff burnout and turnover, which is contributing to this. And I would add a separate bullet on inflation, which is also contributing to this. And the part of the inflation is supply chain issues, which are not captured in the bullets.
Mm-hmm. So it's captured on the slide. I see that you see that it's acknowledged as one of the contributors. I hear you. And you'll see down below that they're talking about, so they're just drawing things from articles about rapid inflation. But yes, all of those are raising concerns. Vicki.
And I don't know where this goes. I know we're talking about the problems, but one of the things we're working on in the Indian healthcare delivery system is community health providers, which means something different wherever you are, but community-based providers who can do in-home home visits and take care of some of those needs, and thinking about how they reduce costs by making sure families get the services they need, helping them understand the services they need, and being somebody trusted that they can really be honest with about their health issues. So I think that's one way we're looking at expanding labor. And I'm also wondering on the previous slide, when we talk about the not reaching the same level of cost in 2019, and how much of that is related to the fact that the people who died were people who suffered from some of the highest health disparities. And, you know, there was a lot of people that we lost during COVID. So I don't know how much that plays into that. I don't know if maybe the actuaries know.
You know, I don't know how much it does either. It certainly is part of the reported trend. And it's yes, it's also it's folks who have you know, kind of our social determinant research, and then also because a lot of them have been the elderly, which also take or older. I don't want to call myself elderly in my mid 50s, but I guess it's me, 50s and up. So they take a lot of the cost. So I don't know, Vicki, that's a good question, but you know, it could be that that's pushing that even lower, but regardless, it's lower. Louise.
Well, I know that we're going to talk about primary care, and you have in this slide the issue of utilization. So I think there's a tension here between utilization at the hospital level and related specifically to COVID, but utilization related to ongoing health cares and preventive cares has been affected, I would say, still. I know my clinic, which is a small privately owned one, is still not back to where we were pre-pandemic. And you know, Mike and some of the others may have some comments on what their health systems are experiencing. So it seems to me that this whole last 2-year period is not going to be at all useful in terms of benchmarking and understanding trends. I'm almost wondering if we need to like just wipe it out and then start all and do a reset. But I have a concern, especially about primary care utilization and trends, that it's going to be very non-representative.
Thank you. I think that's a really interesting question because, of course, we're not looking at it by service category. We're looking at it in aggregate. But what I hear you saying is that utilization in certain types of providers or certain size of providers might be very different and not follow this kind of large trend. What I think will happen is that we will get more granular information as things, you know, unfortunately, looking at this information is always a little bit in the rearview mirror. And you're right, it will take some time to develop. But I will keep my eye out for anything I see, Louise, that calls out primary care separately from this. So we went back to the slide of contending with rising costs. This is a stand-in for inflation, which is personal consumption expenditures. So this is, I am not an expert in personal consumption expenditures other than what I spend myself, but this is apparently a good stand-in to look at the impact of inflation and on people and on purchasing. So you can see this, it's a pretty exaggerated upward trend. We go back all the way to 1995 here. Really, this is acknowledging with data that, you know, what Mike has said, what Mika has said, what we've all been saying, this is an unprecedented situation because you see that jumps up so high. And then the acknowledgement among Kaiser Family Foundation and Altarum Institute and the Brookings Institution that growth of healthcare spending, that economic changes it's lagging. So it kind of goes back to, again, my statement that you have to look at these through a rearview mirror because the impact on price lags based on the contracting periods, although they can be a strong predictor of healthcare spending growth. I don't think that's telling us anything that we don't kind of already know. Inflation is bad. COVID is definitely having a huge impact on utilization and spending, and it may take us a while to see what the impact is. on healthcare spending. So the board was specifically shown this slide again. This is your slide for revisiting the cost growth benchmark. And so they engaged in that discussion. I really encourage you to go back and listen to that portion of the board presentation last month if you would like to understand more of their conversation. Can't capture it, hard to capture it in slides for you. It's about a 25-minute conversation toward the end of the meeting. So this is the trigger language for revisiting the benchmark. They looked at that, they agreed they understood what that was. And their conclusion was that they are not going to revisit the benchmark, meaning change the benchmark methodology now, that they are going to monitor the situation and ask for regular updates about the impact, and that they understand the context of inflation and COVID is going to have a huge impact on benchmarks. Those are basically the three conclusions that they came to, but it was a long conversation. Kind of the tenor was, this is, we need to be sure that we understand these impacts before we're going to change the benchmark. We don't know what we would change it to based on what we're seeing. The information is not developed in a way that we can have confidence in which way we should move, but that they're going to monitor and they're aware of the context. So again, I'm not stating as well as they did. I encourage you to go listen to that conversation. And of course, if you have more feedback for the board, you're welcome to provide it. Mike.
First of all, I want to acknowledge the board's conversation. Although I didn't listen to it, I trust your summary of it, and I appreciate it very much. I think that's healthy, and it's encouraging to hear how they're recognizing that we can't. Yeah, I liked Louisa's concept of a do-over. Maybe we should just do a do-over. COVID didn't happen. I think she said reset, but the thing I wanted to point out, in addition to just praising the board's willingness to take a serious look at a sobering look at the environment with which we're timing's everything, right? I mean, when this was a glimmer in some legislator's eye relative to form this board, the macroeconomic issues we're talking about today weren't forecasted. And so to now be deploying them in an environment like we're in is really kind of a significant disconnect with the timing. But again, the fact that the board is recognizing that is encouraging. So that's a long prelude to the comment I was going to make, which was that, I've run into a number of people in both healthcare, but mostly outside of healthcare, who are using the term that as COVID moves from a pandemic to an endemic stage, if that is to occur, things will return to normal. I would submit that that will not be the case in healthcare for many months, if not multiple years to come. Mm-hmm. And so COVID may have been a catalyst, but there have been extenuating circumstances, including Russia's invasion of Ukraine and issues that are associated with our overarching political environment. I mean, it's just, there are a lot of extenuating circumstances. Again, this healthcare staffing shortage might have been exacerbated by COVID, but it's going to be with us for a long time. And so I want to make sure that the board understands that as it, hopefully BA2 won't take on like Omicron did, although our incident rates are going up again. It's not going to be normal. Normalcy from pre-pandemic is gone in large measure because of the healthcare staffing shortage and because of inflation. And I know I'm piling on, and the only reason I'm piling on is because I'm trying to separate those two things from COVID. They now stand alone. with or without COVID incidents.
Thank you, Mike. I think you're absolutely, I think that is actually part of the flavor of the conversation as well. This thing has happened to our healthcare economy, to the national economy, to all of us, to the nation, to the world. Well, I could either stop everything, or I could, it's like, if I want to make a change, I need to have some roadmap to making a change, which I don't have yet. And it did come up again in the conversation that we're doing a benchmark. We're going through an exercise to collect transparent data in a different way. We're developing a cost driver analysis. And as we develop them, hopefully it will become clearer to us based on the national set of experts and analysis, and Washington, as we all move through this experience for however long it takes, we'll get more information. So it was a fairly nuanced decision to say, let's keep it and monitor. Again, listen to that conversation, but you're right. I don't think anyone thinks this is going to be over soon. I don't think anyone on the board thinks that it's going to go back to perfect baseline. I think monitor to them means live through it and keep forging forward with what the legislature has told us to do, and make adjustments when we feel more confident that we understand how to do it. So I would stay tuned for that, and I appreciate your comments. I am going to pause now. It's 3:39, and I apologize to anybody who has been waiting to make public comment. I am a little bit late, but now is the time for public comment. Anyone wishing to provide public comment, please state your name and your affiliation before speaking. And of course, you are welcome to provide comment in writing at any time if you don't wish to speak now. So I am going to pause. I'm going to look at chat and see if anybody is indicating they'd like to speak there. And please unmute your mic if you have not and wish to speak. Okay, if you're trying to speak, I cannot hear you, so please unmute. We'll give it one more minute. Okay, I am going to close this period of public comment. Reminder, you can provide comments in writing to any time to the Healthcare Cost Transparency website or to me. Looking at time, I'm sure that we can at least touch on the primary care. The next slide is about primary care. It's one slide, just an overview. And then I think I'm really hoping to have a good discussion about benchmark reporting. So I don't want to embark on that in the last 10 minutes. So we'll do this slide and I will put over the benchmark reporting discussion. We do have time for that. So I don't know how many of you are aware that the board was handed a new responsibility in SSB 5589. So what this bill does is create a primary care expenditure target of 12% of total healthcare expenditures. So total healthcare expenditure is a term of art that's found in the board statute. That is what we are compiling as total healthcare expenditures in Washington. That is different than total cost of care, for example. So they've tailored this to kind of the cost benchmark work in that. One of the primary purposes of the cost benchmark is to figure out total healthcare expenditures. The cost board is required to report to the legislature, and they're required to report on these things, which have in them the requirement to develop them. So how to define primary care for purposes of measurement. The current level of primary care expenditures, methods to incentivize achievement of the 12% target, and reimbursement practices supporting legislative goals. And those reports, the first one is due in December, and they will continue annually for some period of time. So another part of the bill is that the insurance commissioner may include an assessment of a carrier's primary care spending in rate and form reviews and require reporting. And there is not more information than that about how the commissioner should do that. So this is, I think it's interesting work. Of course, there has been a tremendous amount of work done around the state on primary care. This year, you may recall that the board determined to use OFM's measurement of primary care as it looks. It's one of the categories that we'll be looking at in our total cost of care benchmark. So, I mean, I'm sorry, in our toward the end of the meeting, all the words just want to come together out of my mouth. The cost benchmark data call is split into 5 categories, subcategories. It may be that we'll take a deeper look at primary care in there, and we'll be using OFM's measurement. But there has been a lot of work. I realize there's a committee in Washington State that's looking at the definition of primary care. There may be others. So I anticipate that the board's responsibility here will be to convene existing work, to receive a proposal, and to make recommendations to the legislature about how to define primary care. Because of course, measuring it all depends on how you define it. I mean, we can't even really, if we're going to do a new measurement, we have to talk about a new definition if we're going to measure it that way. So there are no specific plans underway. There will be a period of stakeholdering to ask certainly this advisory committee and many other groups in the state about how this work should be accomplished. So I would say that the board is a structure within which existing work will be rolled into, and we'll take advantage of it, because the board themselves as purchasers are not experts in this. So that planning is in development. And when I say in development, it's at the very beginning. So now is a great time to send me an email and say, this is what you need to do. But there will be more formal methods of receiving input about, it may be that about whether we need to convene. Some of the options are to convene an additional committee called the Primary Care Committee and convene membership there. Another option would be to simply allow the committees to continue and make recommendations to this committee, who could then review and recommend to the board. I mean, there's several ways to look at it. So I wanted to make sure you were aware of that. And it's my understanding some other of our cost benchmark states have primary care expenditure targets and work to measure, and it is a separate effort than cost benchmark. It is not part of the cost benchmark data call. That would be both Oregon and Connecticut. So we are learning a little bit from them about how they technically structure this work, and we'll continue to do that homework. Louise, I see your hand.
Yes, I just want to comment that the BRE Collaborative produced a report on primary care last year. And a couple of years ago, OFM had to report to the state on primary care expenditures. And I, and probably others here, participated in that. And both of them were very involved discussions, included very involved discussions about what is the definition of primary care and who provides primary care. And I would truly encourage using one or both of those reports rather than anybody starting all over again, because I think what we would end up with is a protracted period of time during which people debate what has already been debated. And I'm not going to say that I fully endorse both the expenditure report and the BRE Collaborative report as being the best ever. But I really think, since we've brought together so many stakeholders in those two forums, that they are the place to start rather than convening another group.
Thank you, Louise. That's very helpful. And if I didn't say it straight enough, it's absolutely my intention to capitalize on what's been done. And the time frame the legislature has given us is fairly short. We don't have time to invent it from the ground up. We need to take advantage of what has been done and the best thinking and make some decisions around it. I appreciate that. I will certainly take notice of both those things.
Well, and again, this is a very COVID-related issue, because the OFM report was done pre-pandemic, and if that was revised or recalculated now, it would look very different. And it's just such a small percentage of total expenditure that's primary care. It was only 4 to 5%. Now it might be even less. And I think the critical element of this legislation is this is a target, it's not a mandate. And consequently, nobody's saying in this year we have to increase it by this much, and this year we have to increase it by this much. So how we actually operationalize achieving a target of 12% of total expenditures is probably the more salient issue than spending a lot of time discussing what's the definition.
Thank you. I think that methods of incentivizing is interesting language for the statute to use. So I think operationalizing will be a big part of that. Any other initial thoughts or comments about this primary care bill? Okay. Well, we've all done such a good job that we get 11 minutes back in our day. Please use them how you will. I really appreciate, as always, your fine thinking and feedback. The recording and summary is going to be posted shortly on our website, as it usually is. The next meeting of the board is on April 20th. And again, that is going to be a review of session. The board specifically asked for both things that passed related to cost and cost interventions and things that were discussed but didn't pass. Then we will also hear some contextual information about the primary care environment, kind of an educational. I hope, Louise, my intent in asking is that will be Emily Transu from HCA is going to talk about what work has been done, what resources there are, and some level setting on primary care. And then we're getting a report on value-based payment. Our next meeting is on June 2nd, 2022. And what I am realizing is, given the meeting schedule of the board, the data committee, and this, that there's a possibility that I may need to develop stakeholdering via email, because timing has always been a bit of a challenge and is becoming even more challenging. So I'm just letting advisory committees and the board know that at some point I may need to invent a process to say, okay, here's what I need you to give me feedback on and send it out by email. I will try to do that very thoughtfully and use it as little as possible, but I want to be sure that our feedback loop remains intact. Thank you all very much. Have a great afternoon. Bye-bye.
Thanks.